Good afternoon, everyone, and thank you for joining this ERA seminar. In the seminar today, we hope to learn about oral potassium binders, particularly focusing on lessons that we've learned from the COVID pandemic and our clinical experience. So we hope this is going to be an interactive but informative seminar. My name's Smeeta, and I'm a nephrologist from Salford, which is in the north of England. So we have some fantastic panelists with us today. I'll go round individually and would be grateful if they could introduce themselves and where they're from. So I'll start with Professor Lucia del Vecchio.
Hello, everybody. I'm a nephrologist. I've been working for nearly 20 years in Lecco, which was one of the first stops which has been hit by the pandemic in 2020. And then in the course of the pandemic, I moved to another hospital in Como, which is a nearby city on the Lake of Como. And like that, I had the opportunity to see different ways and organizational issues in dealing with the COVID-19 pandemic.
Thank you, Professor Del Vecchio. Yes, absolutely. You very much were at the front of the wave that came across Europe. So I'll be really interested to hear how you introduce you, because you work with me. So Dr. Poulikakos is a nephrologist at Salford Royal. He's also the head of department in the area and has research interests in a range of areas, including cardiorenal syndrome, and ECG changes, electronic change, terrible, isn't it? ECG changes in patients with CKD, particularly those on dialysis. So you can see why potassium might be particularly relevant to somebody who has an interest in electrophysiology. But today, hopefully we'll hear more about how his department managed hyperkalemia or used potassium binders during the pandemic. So hopefully lots of clinical practical experience to be shared. And Dimitrios, I'm hoping you're sorted now. Do you want to say hi?
Is it okay now?
Yes, excellent, super. That's a relief. So I won't have to talk for you for an hour.
Thanks for the introduction. Yeah.
No problem. I hope I did you justice, apart from the ECG thing. Okay, so I'm going to start with where the pandemic started for many of us, which was in Italy. And although we knew it was coming, and even though we knew there was an issue in China, I don't think any of us really believed it until it came to Italy. And so, Lucia, it'd be great, not great perhaps, but it would be good to hear your views and certainly how it felt when you were there and how potassium binders were used in that setting.
Okay, thank you. Well, for us, it has been completely something completely unexpected and shocking experience for hospital and all the inhabitants of the area. And since at the end of February 2020, we were all on holidays, skiing, and the next week everything was shut down and the hospitals were in full emergency. And well, we were completely unprepared from the organizational point of view. And the dialysis unit had become a very, very stressed area for two reasons. First, because we have had many patients affected by COVID-19. And unfortunately, many of them died, especially during the first wave. And the second reason of stress was due to a lot of cases of acute kidney disease requiring dialysis. And probably this was even, at least in the first wave, it was even more difficult than dealing with chronic dialysis patients. Because as a matter of fact, we succeed, different from the English experience, to guarantee dialysis to everybody in the usual shift. But we got many difficulties in guaranteeing dialysis outside the dialysis unit. And in this respect, the possibility of using a potassium binder would have been very, very useful in order to delay this treatment and reduce the pressure. And new potassium binders were not available in Italy in 2020. So we didn't have the chance to use as in the UK they did. And so I just speculate what I would have done if they were there. And probably they could have been very, very helpful, certainly.
Oh, right. I hadn't appreciated
Because
that. Yeah, I hadn't appreciated that you hadn't had access to them in that way.
Yeah.
Did you have access to the older binders then?
Yeah.
And they have their own challenges, don't they?
Yeah, I mean, you can use them also in the acute setting for moderate hyperkalemia. But I mean, it's a treatment that you cannot usually in acute patient, you give it once, 2 days, but you don't leave the patient for many days. So they are not really an alternative to dialysis treatment. And conversely, the new drugs, you can give them for a longer time. You are safe, that they are better tolerated. And also because many patients with COVID-19, especially in the first wave, especially patient on dialysis, had as a presenting symptom of diarrhea. So also the idea of giving, and we are also had a lot of problem with nutrition. So giving sodium polystyrene sulfate was not probably the best option.
Oh gosh, right. So yeah, you had multiple challenges and on that front, and you've touched on the UK experience was a bit different because we had access to those, and I know David, we were talking earlier that your team have published on UK experience on that. It'd be really good if you could give us a summary of what your findings were in relation to the pandemic.
Yeah, sure. Thank you. Yes, so I think before the pandemic, exactly as you say, Smeeta, we were not, until it hit Italy, we weren't, I think, any of us quite ready for exactly what would happen. I think we were already aware of the use of binders, and we had a bit of experience with them in the hospital. We were, thinking of them really. We have a kind of a hub and spoke model, if you like. In like a lot of UK hospitals, we have a main, if you like, tertiary referral hospital with as the teaching centre, and that's where the dialysis is done. And then a lot of our local district general hospitals can do filtration on intensive care, but can't do dialysis. So we are often used to the problem of maybe patients being on binders, which, as we know, have got their own problems, or repeated courses of insulin dextrose maybe, which can cause hypoglycemia. And we were starting to use binders a little bit, but yeah, in the first wave of COVID, obviously renal patients were very, very badly affected, and I guess that's not surprising. They have all of the risk factors: advanced age, high prevalence of diabetes, other cardiometabolic comorbidities, hypertension and ischemic heart disease. And some were on residual immunosuppression from glomerulonephritis or from failed transplantation. So they were at high risk. And I remember just looking back at some of the statistics from that first wave before June of 2020, across the UK, there'd been 4,000 cases in dialysis patients and 1,400 deaths. And actually in our centre, Northwest London was one of the earliest places that the pandemic hit in March and April 2020. We've got 1,500 dialysis patients. And again, before June of 2020, we had 1,500 cases and 94 deaths. We shut down our transplant program pretty soon after the pandemic hit. And so we were kind of left with this problem that we could only dialyze in our centre, and locally the intensive care units were filling up very fast. So something which often happens at our centre, which is that patients go to another hospital with renal failure and have to have filtration on intensive care for single organ failure before they come to us, was much less of an option. And sort of taking into account that things like Dialyse trial had shown that binders were safe in dialysis patients, we were we were giving people who were hyperkalemic at other centres, and we were struggling to get across. We were giving them our local use is mostly with Lokelma, that's on our formulary, but I think the same would go for Potassium as well. So we had we did a little survey of our practice at that time, which was led by one of our registrars, Rakesh Datani, and he did a lovely job writing up our sort of early experience. So we used binders in patients with AKI. We also used binders in pre-dialysis patients, where we were having to cancel, say, some elective work like line lists and PD catheter insertions. And so we were then having to postpone a couple of patients. And so we tried to work out who was safe to postpone with a binder. And we did that for 4 pre-dialysis patients. And sort of the average potassium at the time we started that, in those, I mean, it's a very small sample set, but they had a potassium of about 6. And then 2 started, and they all started on either 5 or 10 grams per day. And then they started hemodialysis around 8 days after that. And then we had 19 COVID positive hemodialysis patients who in that initial wave were facing delays, awaiting delays to getting hemodialysis with us, because they were inpatients in other hospitals. So they experienced on average about a 3.5 day wait between dialysis sessions, and we used they did okay. Actually, we had we didn't have any sort of potassium related sort of arrhythmias or issues there. They were all starting a variety of doses, mostly actually 5 grams OD, and had peak potassium levels of under 6. So actually, having feared that we would run into a lot of trouble with people having delayed dialysis and really bad hyperkalemia, we had a pretty sort of, it's our sort of initial small experience, but we had a pretty positive experience of using binders. We only had 1, I think, episode of hypokalemia, going down to 2.8, but otherwise there were no adverse events, and actually that was kind of our experience locally at, if you like, our peripheral hospitals that we work with. And then Rakesh did a survey of all the renal units in the UK, which is 71 units, and actually undertook that in the pandemic. So he actually got a decent response rate of 26 of those units responded, given how busy everybody was. And what that was quite illuminating, in that 73% of the units reported that they had used binders before the pandemic. So yes, as I say, they were in use before the pandemic across the UK, but half of them reported increased use and no one reported a reduction. And in terms of the UK practice on binders, basically it was about half and half between Lokelma and Potassium. And so when we asked the reasons why people had what the hyperkalemia that they were treating was in the context of, generally actually higher incidence than us of managing AKI to try to sort of allow recovery before dialysis, and about 27% was to delay giving RRT or to renal replacement therapy, or to bridge delays in dialysis schedules. And there was a small number of units, just 2 of the units actually were able to step down some of their patients with some residual function, 2 of the 23 units reported around 20% of their patients that had some residual function that they were able to dialyse twice weekly instead of 3 times a week. That sort of obviously was a that's a complex clinical decision, not just based on the potassium, but obviously I think that they had more confidence in managing hyperkalemia in that setting with a binder.
That's so much information. So for those of you that can retain it, well done.
Too much, too fast maybe, but please do come back for any of those.
No, it's phenomenal, isn't it? So much. You've given us national data as well as your local experience. So for those of you that can't remember it, there is the paper that David referred to, which was published in NDT in 2020, and the corresponding author is Dietary, spelled Dattani, and we'll pop a link in the chat or send it out later, but it's worth having a look at. And it's interesting that you ended on the discussion with twice weekly dialysis, because that really leads us really nicely to Dr. Poulikakos and his department's approach during the pandemic. So Dimitrios, I'll hand over to you, and then after that, if everybody can think about questions to ask each other, that would be great. And also to our audience, do feel free to put in any questions into into the Q&A panel on the side, and then I will endeavour to ask the panel questions so that they can hopefully give you some clear answers.
Thank you, Smeeta. So, thanks for being third, because I think that was the sequence of the pandemic as well. I think it was Italy first, London and Imperial partly hit second, and then we had a few weeks advantage, I would say, by just talking to our friends and colleagues in London, on looking at what happened in Italy. So we have a smaller unit at the Northwest, as I said, and we look after around 430, while at that stage it was 432 to be accurate, in-center hemodialysis patients dialyzing in the main hospital and 4 satellite units. And we were faced with a triple challenge, really. The first one was predicted increased demand of staffing for the dialysis patients because of the need for segregation. So we were going to reconfigure the service as everybody else to have a unit for the suspected or confirmed cases, and then the separate other clean units. We had a very useful document produced by the Renal Association from the influenza pandemic, really, from 2009, that had some modeling and had predicted that if a similar sort of pandemic would come through, one should expect 30 to 35% staff absences during the peak over 2 to 3 weeks period. Then we had the experience from Italy and from London at that stage that there will be a lot of AKI, so more need for dialysis. They had to support the ICU units, and we had a regional plan and a local plan with the ICU that had to go up in capacity in extraordinary numbers, and we would have to cover this capacity. And we had the option in the influenza pandemic plan to identify patients that could reduce dialysis in case we were not able to manage the population because of staff sickness. So we tried to model that, and listening to what was happening in London, I believe, I do not know if it was your center, David, or some other center, that there was a point that they didn't have dialysis nurses to cover the program, and there were junior doctors helping out. And so we had all this sort of information coming through, and trying to design this, what would happen if things are going to come up in the Northwest. The conclusion was that it was impossible to have an elective reduction of dialysis sessions at the heat of the pandemic. We also had some modeling from our colleagues in Imperial, suggesting that about 40 or 45% of our patients would get infected with the various sort of variables that we put there. So we had to make a difficult decision. So a few weeks before the wave came up, we asked the named consultants to identify patients that could switch to twice weekly dialysis, hemodialysis. The criteria were mainly, so we didn't have very strict criteria at the beginning. So it was that the patient had been compliant in the past, that they did not have high pre-dialysis potassium in historical data, that they didn't have large endodylytic weight gains, and they didn't have large metabolic demand. So from the 432 patients, there were just above 170 patients identified as suitable, and eventually 160 something, I think it was 38% of the total population were deemed suitable to switch. And we had a program to do this in a controlled fashion. So we allocated 5 consultants, all the dietetic team and the pharmacy team. Each patient had weekly bloods on the first session of the week, of the twice weekly sessions. And then the criteria, they were looking at potassium and interdialytic weight gains. They were reviewed by 2 consultants independently. And then so absolute indication to go to 3 times weekly was potassium of above 6.5. If the potassium was between 5.7 to 6, then they would have dietetic advice over the phone and they would be reviewed again on the same week. If it was above 6 and below 6.5, we would start a potassium by Leukemia, and they would have a dietetic review and a medical review of the notes and the dialysis and the notes over the next dialysis session of the week. So they would have intensive monitoring if they were hyperkalemic. And then we would do the same if they had large interdialytic weight gains. So ultrafiltration rate of above 10 mL per kilogram or more than 5% of the base for the target weight change. And we monitored this, and this is what is summarized in the manuscript. We monitored this practice for 4 weeks to publish it, but we continued monitoring it until we reverted back to 3 times weekly later in the first wave. So we did not have any patients that suffered from fatal side effects from the twice weekly program. So all the deaths were scrutinized and there was no death associated with twice weekly treatment. We had, obviously, we managed through the pandemic to support the program, to support the ICU. So 10% of COVID AKI in ICU was supported by dialysis nurses. And we had 1.5% overall mortality at the end of the first wave, with about 10% of overall infection rates, which is pretty much similar to what it was in the north. Now, there were 19 patients that had to start on Leukemia. 7 of them had to revert back to 3 times weekly, but it was 4 of them that the indication was hyperkalemia. The other 3 was fluid overload. There was 1 that did not tolerate Leukemia, and there were 9 patients that carried on and actually wanted to carry on after that and maintain on twice weekly. So overall, it seemed, so after the first wave, we reconfigured the program and offered back 3 times weekly dialysis to all the patients. But it seems that in this type of crisis, it is possible if it is in a controlled and monitored sort of fashion for a significant proportion of the dialysis patients to be switched to twice weekly and then revert back to 3 times weekly. I'll stop here.
Yeah, thanks, Dimitrios. So you kind of highlight what happens when you have to deal as an emergency, which Lucia and her team did, a semi-emergency as David's team did, and then the advantage of having time to put in a controlled management plan with safety netting. I'd be keen to hear what David's and Lucia's views are on that approach.
That's I'm just hugely impressed by the planning and the modeling to do that, and I think it's you must have answered our survey as one of the, because I think that actually the for the units that were able to do this were real outliers actually, and it's really great to hear that you had such a positive experience of it. So as my question was that you know, a lot of my dialysis patients, or I don't have my own unit anymore, but when the dialysis patients I see as inpatients, a lot of them would rather be on twice weekly anyway. And I suppose my main question was sort of, because psychologically, did you have difficulty getting some of the people who actually thrived on twice weekly back onto 3 times weekly?
We did not have major issues in putting them. We had questions, but then we said this is what we need to do to improve your long-term outcomes, and we did not have that. We had a few that remained on twice weekly with good residual urine output or very minimal metabolic demands, that it was appropriate to remain. But we didn't have the difficult patients that we had to go back to 3 times weekly because of clinical need.
That's good. And I was interested, my sort of second question before I let Lucia ask was, how easy was that conversation? Because as you said, I suppose one of the things about planning, you know, is that you had some time to do it, but I suppose also you have to be mindful of worrying patients that there's a bit of a storm coming and that it may affect their dialysis, which is obviously a huge part of their life. And how were those conversations difficult on the whole about going to twice weekly?
So at this point, that's an excellent point, David, and I want to thank this amazing dialysis population, the solidarity that they showed between themselves and the solidarity with the unit trying to address, to get through the pandemic was amazing. I mean, they were ready to do anything. I guess they have heard as well, you know, by the time that it came to the Northwest, we already had the first statistics from the association, which were about the mortality in dialysis. So they were very scared, and they were welcoming any reconfiguration plan they thought that we would have.
Yeah.
We had a few patients, I think 3, I just need to look at the manuscript, that were, because they asked, we switched them back to 3 times weekly out of the 160.
Yeah.
So it was not compulsory. It was a discussion between the consultant and the patient.
Yeah, I think you touched just before I hand over to Lucia, you touched on a really important point there. That was, you know, that was such a big thing, especially talking to our dialysis patients as well, is that many of our patients, you know, they knew they were an at-risk population, and they simply cannot shield, and a lot of them come on transport or even by public transport to dialysis, and you know, that's it. Yeah, I think the bravery that often took, you know, because actually with some of their other comorbidities, if they didn't have to leave the house and come to in-center dialysis, you know, they would be fully shielding, and I think that, you know, they had a very you know, it's a very tough situation to be in.
I would like to ask you, well, first of all, congratulations, because really the organizational plan is brilliant. And I have a question for you about nutritional aspects. How much did you reinforce information of on food containing potassium, or the supplementation with a potassium binder, and let's say preventing somehow the need of reinforcing that dietary information?
Yeah, that's a very good point. So this is again thanks to the amazing dietetic team. So every patient was contacted at the beginning, every one of the 168, and had a detailed plan by the dietetic team. And then if they were outside so if they were starting to become hyperkalemic, or the fluid gains were above what we had set as a safety limit, then they would be contacted more than once per week just to make sure that they are doing the right things. Obviously, I'm just taking this point. It was a difficult, so mixed memories now so we were used in Patiromer actually. So we had some experience with Patiromer, and we had to balance the sodium content of Lekelma, which is pretty much 20% of your daily allowance on dialysis. So if you give it, it is at an expense of fluid management when you put them on twice weekly, against the risk of hypomagnesemia and how we monitor for that, or how we would be able to treat that with nutrition or not with the pyramid. And we ended up concluding that the safest option would be to give a little bit more salt. We also gave sodium bicarbonate, sorry, I forgot to say that. So that was going, so we were giving a sodium load, and there was a very detailed interaction by the dietetic team to account for this 20% plus the sodium bicarbonate.
So did you reinforce also dietary advices for sodium intake?
Yeah, it was sodium intake, fluid intake, potassium intake for them.
Yeah.
Difficult dietary advice, really. It is.
I think that probably the fact that the emergency situation helped a lot in motivating the patient.
Yeah, I bet it did. I mean, Dimitrios, your sound is still just a little bit off. We can hear you clearly, but if there's an alternative microphone, that'd be super. But don't worry if you haven't, because we can hear you. Lucia, so I know you've asked a few questions around dietetics, and actually, although the UK had access to potassium binders, what we're hearing is dietetic input is really important and was key to managing those on and off binders. I'm assuming that in Italy at the time, you were very dependent on dietetic support for these patients. And, you know, did the staffing issues and the lack of dialysis impact on your approach? And do you have oral potassium binders now that you use? And how would you do things differently?
Well, they're entering just now, potassium binders, they're just entering now in Italy. So, I mean, our experience is limited. But, well, at that time, we were completely in emergency. So no way to, let's say, use the dietitian or increase the message from the dietitian, because we were in the middle of a war. Let's just to make understand the situation. So we are just coping with, let's say, the ordinary stuff. No room for other possibilities. Also, because in our dialysis unit, we got also, well, we had many patients affected with COVID-19, but also many nurses. So we also had a lack of staffing. So it was difficult to reinforce this kind of messages. Today, I think I work in, I've a number of patients on dialysis under my responsibility. And I have to deal every day with the effort to reinforce the dietetic counseling. And I like a lot the nutritional aspect, and I do believe a lot in patient education, and I do my best. Say that it's very, very difficult for a number of reasons. First, you need a lot of time, and you do not necessarily have a dedicated dietitian for your patient and following them properly. And second, even if you do, you collect well the stories, the dietary habits and whatsoever, patients are not compliant. And so, I mean, you tell every day the same stuff, but they don't hear you. And third point, and I think that in this respect, drugs will be very, very helpful. A lot of time you deal with patients that do not understand you because they are very, very old. They are not self-sufficient. And often the caregiver is not in the dialysis unit when you are performing the visit. So in the end, you have no dialogue with the person who is preparing the meal. So you have a strong barrier to reinforce the dietary counseling. And also probably is not necessarily the best option to just reinforce dietary counseling, because I used to work with a Chilean from Chile, a dietitian from Chile. She's very, very dedicated dietitian just for kidney patients. And she used to say that we have too many stops to have too many red lights for our patients. And if we tell them, don't eat food with potassium, don't eat salty food, don't eat food with phosphate, and in the end, people don't eat. So the possibility to, let's say, it's not that we have a drug and then forget the diet, but gives advice, but leave patient eat more freely. This is my view.
Yeah, so you think that there's the opportunity to allow a better quality of life, because potassium-containing foods are tasty. So an opportunity to provide people with a lax diet, although, and give them tablets instead.
I mean, it's not just a problem of tasty, or it's a problem that you have to skip a lot of vegetables, and then there is patient of constipation. So you have a worsening in the status of your microbiota, for instance, and you avoid vegetables, and you have a decrease in your worsening your metabolic acidosis. And the most important thing that, especially in the elderly, are a high risk of malnutrition, of cachexia, and wasting. So if you put many stops, people don't eat and worsens their malnutrition. And of course, I mean, quality of life, yes, but it's just one aspect. It's more than quality of life. It's just our medical needs.
Yeah, it's multifaceted, isn't it?
Yeah.
And it's interesting that we now have some trial data on the use of potassium binders, isn't it? David and I were chatting earlier. David, how do you think that those clinical trials influenced potassium binding during the pandemic, and how do you think those lessons, coming back to the topic of the seminar, we use them, and we use them a lot in the UK because we had them. How does that experience, coupled with the trial data, how do you think that's going to change the way we use these drugs, and how ought we to change the way we use these drugs moving forward?
Well, I think as we were chatting about this before, and I think these are really interesting questions. And I think what Lucia was just saying now about dietary restrictions and how miserable that can be for dialysis patients, not just psychologically, but of course, it impacts on their general health. And I think that the trial data that there were data that suggested that binders were safe in dialysis patients, was a good thing going in, and that they were well tolerated, and I think that sounds like all of our centers' experience as well. And I think for me, it made me reflect a little bit on the trial data around prevalent potassium levels in dialysis patients. I think I was saying to somebody else the other day that I think when you are, say, a renal registrar or trainee, and somebody phones you and says that someone's potassium is 5.5, you sort of have a tendency to say, well, that's probably all right. I'm not, that's not a 3 a.m. call. But I think then when you've got a dialysis cohort and you're thinking more broadly, if you look at the data around mortality and admission to hospital and rescue therapies, it really just goes up for every, if you are running higher pre-dialysis potassium, your risk of these complications rises. Now, whether that's a marker of other things or whether that is mechanistic is difficult to say, but I think it does flag up to you that those are patients that you need to think hard about. And I think that also what's interesting is how many dialysis patients. It's pretty high in some studies. Maybe others may correct me, but in some studies around 30%. How many dialysis patients actually run serum potassiums of 5.5 or above? So it doesn't go away when you've got people on dialysis. And I think the two things I think that come out of it is, can you we'll see data, I'm sure, in coming years, but can you reduce that risk of sudden cardiac death, which is really high in dialysis patients, as we know, by using binders, by accepting that binders might be a very necessary, useful adjunct to regular hemodialysis? We know that if you lengthen someone's session, well, most of the potassium you're only getting at the extracellular stuff. That's the minority. We know that most of it's probably removed early, and it's sort of the law of diminishing returns. And patients don't really often want to do longer and longer sessions or more frequent sessions, do they? So maybe we sort of think, well, actually, binders, if they're well tolerated, are a necessary adjunct to that. And then I think maybe we can even think about it in a much more positive way of having seen that they're well tolerated. Can we be a bit more relaxed about dietary restrictions, particularly around, having things that we keep telling other patients are good for them, fruit and vegetables, and fresh fruit and vegetables and things like that. And I mean, I'd be interested to know what other panelists thought on that. But I know that clearly there are studies going on in that area, and I think that's a positive thing. I think they probably, for us, the use of binders in the pandemic made us all much more experienced with them, confident with them. In our own, we had real world experience of them working. I think we'd sort of take that into those two areas: patients on dialysis that are persistently hyperkalemic, and patients who struggle with dietary restrictions for other reasons. You're muted.
That's terrible chairmanship. I do apologise. I should be able to figure out the mute button. So yeah, David asked a question of the wider group, but I'd be keen to hear what your take on it is as well, Dimitrios, given that you did have a systematic approach to using potassium binders. Has that continued?
Can you hear me now, or is it?
There's a little bit of fuzz,
is it
but
still bad?
There's a little. It's not bad. There's a little bit of fuzz, but we can hear what you're saying, and that's the important thing. So far away. Don't worry about it.
So from this particular cohort, there were perhaps one or two that still are using the binders, but obviously it's difficult to make a general comment based on this particular study, because it was a period, as Lucia said before, that the patients, and David, that the patients were very aware of the situation, very scared, and the compliance, and I didn't go into the details in the that I described in the manuscript, but the compliance was excellent. I mean, it was not the standard compliance, and this is always a question when one is using a binder in a patient on dialysis with high potassium in general, as to if this is due to compliance issues in general, it might be due to compliance issues to the medication. So is there a risk there prescribing a medication might only comfort, the fear, your fear that the potassium is high and the patient might not take it. But on the other hand, there are patients that may be struggling because of suboptimal access, waiting, a definitive sort of solution, which definitely has place and it's being used like a malfunctioning line, fistula waiting. David pointed out a good question about whether a systematic use, whether would be beneficial in terms of arrhythmias in the whole cohort, and whether, I do not know if there are relevant studies out there, and whether an intermittent sort of potassium binder during the long interdialytic interval would make profiles a little bit more even. So that's, and then it's the last one about microbiota, which I think it's very, very relevant. And of course, it would be very interesting to be able to give fibers that we know that are beneficial in other sort of populations, altering microbiota and perhaps clearing uremic molecules that are derived by the colon and are not affected by hemodialysis. And we can't do that now because there's always a bit of potassium in there. But whether the binders interact with the microbiota is another question as well. But it's an interesting sort of question if one wants to look at this. I'll stop there, my microphone anyway.
No, and you raised some interesting questions as well, and we're starting to get some questions through from the panel as well. So mindful we've got 10 minutes, so I might use some of those. But we've covered some of the clinical trial data, but also identified areas where research is still desperately needed, so that we can answer some more of those questions. And we've also, right into the things like microbiota effect on, patients' other nutritional factors. One of the questions that's come through now is because we've obviously got trial data using 2 potassium binders more recently, which have looked at potassium levels. Do you have a feel for which one's better? So, any views on any superiority or advantage that's of using one over the other? And that's from an anonymous attendee. So I'll put that question to, actually, Lucia, I don't know if you have you had experience of using the 2? And if
no, as I said before, we are just the beginning, but since that we are just the beginning, we have just been confronted, me and the chief of my department, with our chemistry department asking us which one we wanted. And the answer is that it's true, they do the same thing, they lower potassium, but there are definitely 2 different drugs with 2 different mechanisms of action. So it's not possible to say which one is superior to the other. They are simply different. So there is one is better compared to the other in a certain situation. For instance, patiromer reduce potassium more slowly in comparison to sodium zirconate. So you cannot imagine to use it during, let's say, moderate hyperkalemia in the acute setting, for instance. Patiromer does not have sodium, so you can use it more in patients with heart failure. So you need the 2 different options and then prescribe it according to the patient need, in my opinion.
That's good. That's a viewpoint from decision-making early doors. And what about the 2 people that have used it? Any views on actual usage? Or are you going to echo what Lucia has said?
I would agree. I mean, there are 2 agents that decrease the potassium levels. They are different agents. We touched on this before. So patiromer needs more monitoring, blood test monitoring of magnesium because of the way that it acts. Lokelma has the sodium content that needs to be taken into consideration. So I think you need to look at the individual patient. As I said before in the study, because of ease of monitoring, we went for Lokelma during the pandemic because you don't have to monitor magnesium, but it depends on the individual.
David.
Yes, I'd echo that. I don't have a strong fit. I mean, partly because of the way that formularies work at hospitals and locally, I have much less experience with Patirima. I think that they are both better than the alternatives, and I don't have a strong feel. But I think, just going back and talking about, things that have, lessons you can learn post pandemic. As I say, we have Lokelma available in our hospital, and we've noticed that so that the use of insulin dextrose has dropped. One of our excellent junior doctors has been undertaking a survey of that, and just our kind of real world experiences that we're using less insulin dextrose, which I think is that's a really good thing, actually. And if we can maintain that, and similarly, when we often have to keep people's potassium a bit lower with things like sodium bicarbonate, which again have a salt load. And I think, yes, which I don't have a strong feeling between the two, but I think that my current experience is that binders give you a lot of options that weren't there before.
Yeah, and I guess they're probably not dissimilar to the old phosphate binder story, aren't they? Not all phosphate binders are the same. We are now getting potassium binders. I suspect more will come, and there will be different, and you'll adjust them slightly. Super.
Not sure anyone will ever do the head-to-head trial, will they? So it'll be. So I think
no, I think
whichever one you can get is probably.
Yeah, it'll be interesting to see what other things come out. Maybe we'll have an iron-based potassium binder. Who knows? Okay, a couple more questions. Terrible, Chair. This came in before the meeting. What are your views? Do you think hyperkalemia increased during the pandemic? Or do you think any increases might have been because of an effect of our response to the pandemic?
Respect to COVID-19 infection?
Yeah, I think so.
Well, as a matter of fact, COVID-19 infection increases serum potassium in a number of ways, from acidosis, also respiratory acidosis, to cellular lysis, and also as a manifestation of acute kidney injury. So we observed many patients showing hyperkalemia in the wards.
Yeah, so there were so many reasons for the patients to be hyperkalemic. The COVID-19, the delay in accessing dialysis, as well as the having to not even start because there were no dialysis slots, never mind just twice weekly. So yeah, definitely another multifactorial cause there. Excellent. One more question. I think we've got 6 minutes before I wrap. Using potassium binders to support incremental dialysis, views. What do you think? So I'll start with, if you can keep your answers to a minute, that'll keep us perfect. And I'll ask each one of you, because that's where people are looking at using these meds moving forward. So I'll start with David.
Well, I think I am going to hand that one over to the outpatient dialysis experts. Actually,
there you go.
I can see the logic, but I don't yet have much real world experience.
This is a difficult one, Smeeta, because in incremental dialysis, assuming that you have significant residual urine output and compliance that can maintain, and a patient that can be maintained safely twice weekly. If you have hyperkalemia and incremental dialysis, probably the time to look at switching to 3 times weekly, I think, because we get again back into the previous question about compliance and whether you can safely continue, so I wouldn't think it's the best. There might be patients on an individual, on a case by case that might be applicable, but as a general rule, I think it's best to switch to 3 times weekly.
I'm more positive on that. Because especially not for young people, because I remain convinced that the more effective the dialysis, you dialyze a patient who is younger, the more you guarantee him well-being and a longer life and a better condition before transplantation. But if we have a lot of people older than 80 years old entering dialysis, 80, 85, with somehow a reduced life expectancy. And so you ask yourself, I'm really doing his best by moving him to 3 times dialysis. I mean, it remains, if it's not, of course, with malnutrition and stuff like that. I mean, if you have a chance, of course, you need a certain amount of urinary output and a minimum of residual renal function. But probably if you have another opportunity to keep the patient longer in twice weekly hemodialysis, probably you do something good for the patient.
Yeah, I suspect Dimitrios will agree with that. We just have a different population. We don't have many 85-year-olds that start dialysis.
We have so many.
I know, I think our population is perhaps slightly unhealthier than yours. So one last question has fired in before I close. This is from John Golden. So on dialysis, so I'll direct this towards Dimitrios again. When you gave these people binders, did you see a change in the Dialysate potassium solution, the bath? So less delta K2, more switch to K3, or is that something that we can't answer because we didn't really look at it?
So we didn't, and that was a decision, a consensus. We didn't change the dialysate in these patients, so we didn't switch them to low potassium baths. Long discussion whether, you know, the difference between the bath and the dialysis potassium is important in terms of arrhythmias, and we didn't measure other than the serum potassium at the first and then subsequent session. We didn't do other measurements.
Yeah, exactly. The changing potassium in the dialysate is a controversial area, isn't it? But I can see why some people, desperate times, may have felt that was a thing to do. So 1 minute to 5. Thank you so much to the panelists. I think we covered pretty much everything from clinical trials, future research directions, managing in warlike, I think, Lucia, how it felt in Italy, to a controlled introduction of twice weekly dialysis, all the way through to how we might use these drugs in the future. So I'd like to thank the panelists, and also I'd like to thank the attendees and for sending some questions in that really did facilitate the discussion. So thank you, everyone, and have a lovely evening.
Thank you very much.
Bye-bye. Thank you.
Thank you.